First question, and maybe I can ask Dr. Leblanc if you wanted to answer this question. You can either do it in French or in English. What are the advantages of pomalidomide and Revlimid for post-stem cell transplant in maintenance?
Donc, est-ce que vous m'entendez? Oui. Donc, la question, c'est dans un contexte de maintenance, après une autogreffe de cellules souches hématopoïétiques, quelle est la place du lénaludomide, du pomalidomide? C'est la question?
Pomalidomide et Revlimid.
Donc, le Revlimid, lénaludomide ou pomalidomide. Donc, la présentation que je vous ai faite sur la maintenance était en particulier sur le lénaludomide parce que c'est là où on a le plus d'études matures. Avec le pomalidomide, on n'a pas d'études aussi matures, des études de phase 3 qui démontrent le bénéfice du pomalidomide. Il n'y a aucune indication d'utiliser en maintenance le pomalidomide actuellement. On n'a pas les études pour ça. Pour quelqu'un qui est en première ligne de traitement, si on utilise la maintenance, les études les plus matures sont avec le lénaludomide ou encore avec le bortezomib.
Merci. Does anybody want to add something to the question? No? OK. Je voudrais, pour ce qui est de bone damage and pain beside bisphosphonates, do you recommend vitamin D and vitamin K2 along with any calcium, magnesium supplements? Dr. Reece?
So the question was giving vitamin D and vitamin K with bisphosphonates?
Correct.
Correct. I think going back, I think it's always easier to follow what a trial did in advising patients what to do off the trial. And the original trials of bisphosphonates, either pamidronate or zoledronic acid, did give vitamin D and calcium. So I don't myself know of any role of vitamin K. Now, there is a caveat with that, is that if myeloma is active, one of the symptoms in about 10% of people can be a high calcium. And you don't want to augment that by being on vitamin D and calcium, which maintains that homeostasis in your body. On the other hand, the bisphosphonate, one way to think of it is when you get that bone builder, it takes the calcium and vitamin D in your diet and builds it in the bones. So you want to have the building blocks to keep bones building, not being broken down. Fortunately, your doctor, I'm sure, checks your calcium every time you come. And if someone starts having a high calcium, then those drugs are held, or the replacement, the vitamins and calcium D. There is also a not rare, usually not serious abnormality of the hormone system called hyperparathyroidism. When your glands next to your thyroid, which help your body's calcium level normally, become a little overactive. So you have to watch out for that. There's usually not any specific treatment except to minimize calcium replacement. So bottom line, in the ordinary sense, vitamin D and calcium are good adjuvants to take with bisphosphonates, but your doctor should be checking your calcium, and if it goes up, they're held.
Perfect. Thank you. Anybody else wants to answer? Okay. Question for Dr. Neri. Which medications are used to help neuropathy?
This is a good question. We usually suggest either gabapentin or pregabalin, which is Lyrica, but we have to understand the cause of it, first of all. If the neuropathy caused by myeloma, because, myeloma, unfortunately, the production of protein can affect the nerves as well, so priority is, of course, to taking your myeloma under control. If it's the neuropathy, it's caused by the treatment, and you heard about the Velcade. Unfortunately, protease inhibitor is the well-known cause of neuropathy. We try now to use, instead of IV, we move to Velcade sub-Q, and seems to be very helpful. But nevertheless, when the neuropathy appears, we always ask the patient, are you feeling tingling, numbness? Always report to us right away, because we don't want that to become what we call a grade 1, when this is just an initial neuropathy, to grade 3 will become painful, and then the damage to the nerves can be a bit more sustained. But when the symptoms are there, we suggest to start this drug that seems to be helpful.
Thank you. I've got a question for... Oh, Monsieur Duquette.
Oui, j'aimerais juste rajouter, là, parce que ça me fait penser, parce que souvent, il y a des patients qui ne veulent pas dire aux médecins ou aux pharmaciens ou peu importe qui les voient, qui commencent à avoir des problèmes parce qu'ils ont peur qu'on va arrêter le traitement. C'est très important, au contraire, d'être au courant. Ça ne veut pas dire que si vous nous dites « Ah, je commence à avoir des problèmes », qu'on arrête les affaires, mais on peut agir. Fait que ça, juste un petit point, là, quand vous commencez à avoir des symptômes, il faut en parler, il ne faut pas les cacher. C'est très important.
Merci. Another question in that vein, this was a question from earlier this morning. You mentioned organ damage, skin inflammation, dental issues. Can patients' eyes be affected too? For example, posterior sclerosis, inflammation of the back of the eye in myeloma patients due to treatment. Dr. Sebag.
Sure. Probably the most common ocular side effect we see is blurry vision in patients who, for example, are on dexamethasones and their sugar goes up. That could be one of the first signs that the sugars are not well controlled in a patient. Again, myeloma patients tend to be a little bit older, a little bit more prone to diabetes, and if it's not well recognized, that can be an issue. Probably the second most common eye side effect that I see is cataracts. And again, partly is the age of the patients, and partly is the fact that we use dexamethasone or cortisones, which can help mature the cataract, if you like, or make it accelerate its process. So those are probably the two most common ocular toxicities that I see.
I think if I'm interpreting the question, there is a very low incidence of ocular problems with the bisphosphonates. I can say, having used them for 20 years, I don't think I've ever seen it. Mm-hmm. What we do see, and it's not reported in the literature, and we've been trying to get someone in our center to write it up, is we see styes. We see around the rim of the eyelids, the eyes may get red or irritated or even get little styes. And we believe that is a not well reported side effect of bortezomib, of Velcade. And it's due to, if I can pronounce it, we have little Meibomian glands. You can say it. Meibomian glands in our eyes that I think help with tear production and making the right proteins that have to lubricate our eye. And I guess with proteasome inhibition, maybe the protein components are altered and they get blocked, but styes are really common, or kind of red eyes. So we send them to our eye doctors at Princess Margaret, and their recommendation is almost always local management. Warm soaks, good, what they call good eyelid hygiene, sometimes topical antibiotics. Rarely, if they get out of control, someone has to have antibiotics like for an infection. But we see this all the time, and I'm curious if other centers do too, or is it?
I can't say we see it all the time, but I have recently seen it. It's so I see it. I can't say I've made the association personally, so it's interesting to hear this.
I think everyone we've seen that has had this complication has been on Velcade.
Thank you. I've got a question here that's relevant for everyone on the panel. Should all myeloma treatment centers in Canada do FISH on diagnosis? So I don't know if Dr. Leblanc, you want to start?
Donc, si tous les centres au Canada qui traitent le myélome font des fiches, les fiches, donc, c'est les analyses génétiques pour mieux caractériser les cellules myélomateuses pour avoir une meilleure idée pronostique du type de myélome qu'un patient a. Donc, ce n'est pas nécessairement tous les centres qui le font, mais pour des centres qui ne le font pas, il y a des corridors de services qui sont organisés pour que ça soit fait à l'extérieur. Donc, tous les centres au Canada ont accès à du fiche. Est-ce qu'on doit le faire pour tous les patients et un patient à tous les moments où la maladie récidive? Pas nécessairement, mais tous les centres au Canada ont accès aux fiches.
I actually feel very strongly that they should do it because it gives us not 100% accurate, but it gives us a hint of a red flag that someone's myeloma is either going to be fairly well behaved or statistically more likely to want to come back sooner and potentially more aggressively. And I think even some of the centers in the past, their pathologists didn't want to do it because it didn't affect treatment. But I think patients need to know what their enemy is and what they're up against. And the analogy is acute leukemia. For decades, we've been doing chromosome analysis in acute leukemia. It only changes one type of treatment, but you can know what your risk factors are. We are also in the era of targeted treatment, and there is a new drug coming out for 414 translocation, and one coming out targeting 17p deletion. So it's good to know what your enemy is, and it's not that hard to do FISH for a couple of high-risk cytogenetics. I'm sorry, you were going to say something too.
I will probably have to. So in our probably this. Okay, now it's on. I will completely agree with Donna. I will probably add until the genomic sequencing will be available, and that hopefully will happen in a few years, because when we sequence the genome, that part of information will be there. FISH needs to be done. In our center, we do always for 14, 16, and 17p. And then I stressed this morning saying also at relapse, the FISH need to be repeated at least for deletion 17, because the disease can come back differently, because then disease can be more aggressive, and we need to know that piece of information when we retreat you at the relapse as well.
Dr. Sebag, do you want to add something to that?
No, I think it's been well said. I think I'm not a big proponent of doing FISH outside of clinical trials for patients that relapse. At diagnosis, yes. On relapse, I'm more interested in those who enter clinical trials than those who don't. I don't think it adds that much information to what we're going to do, because we still treat patients with the limited number or available therapies that we have at the moment, until we have more targeted therapies, as Dr. Reece has mentioned. But certainly at diagnosis, this is something that we offer, or we do, on every patient.
Okay, thank you. I've got here a question in French, but I think I'll translate it as well for Dr. Reece and Dr. Sebag, because I think it's an important one. It says, actuellement, l'approche en myélome indolent est non interventionniste, et on attend l'évolution plus importante pour le traitement. Y a-t-il possibilité de traitement d'autres dès le départ au lieu d'attendre l'évolution de la maladie en myélome multiple? So the question is, smoldering multiple myeloma is currently not being treated. It's watch and wait. Is there opportunities, or is there medication that could help patients in that condition before they get to full-blown multiple myeloma?
Sure.
Dr. Sebag?
Je peux le répondre en français, si vous voulez. OK, d'accord. donc, pour le myélome qui est smoldering, donc c'est un myélome qui est non clinique, qui n'a pas de symptômes cliniques, mais quand même qui représente une capacité de transformation en myélome clinique qui est assez élevée. Il y a deux problèmes. Un, c'est comment identifier ces patients qui vont se transformer en myélome plus tôt que plus tard. On sait qu'il y a une population qui prenne beaucoup plus de temps, et peut-être que pourront bénéficier sans traitement pendant une longue période de temps avant cette évolution, si elle a lieu. L'autre, c'est avec quoi? On a une étude qui a été faite il y a quelques années avec le Revlimid ou le lenalidomide. C'était une petite étude, mais néanmoins qui est intéressante. C'est sûr qu'on ne veut pas sujeter nos patients de myélome, des smoldering, des patients qui n'ont pas de symptômes, à des thérapies qui sont toxiques. On veut leur donner quelque chose qui est peu toxique, facile à prendre.